Hello, my name is Dr. Roger Henderson and I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify, Apple Podcasts and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. Now you can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can also visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings which occur throughout the year. Now in this episode, one of our listeners has asked whether we could talk about prostate cancer, and this is in view of the recent news about Sir Chris Hoy showing that he had terminal prostate cancer at a very young age. And this has opened up a wide debate in the general population about when we should look at PSA screening in younger men. So I think this is quite a good call, especially because 1 in 6 men in the UK will be diagnosed with prostate cancer in their lifetime. And it is the most common male cancer in this country, with over 55,000 new cases every year. Now, the 3 main risk factors out of a number of risk factors for developing prostate cancer are increasing age, not surprisingly, ethnic origin, and genetic predisposition, with age probably being the most important, although about 1 in 4 cases do occur in men under the age of 65. Prostate cancer mortality, though, is strongly related to age, and not surprisingly, the highest mortality rates are in men aged 90 and above. We can sometimes forget that prostate cancer is most common in black males, followed by white men, and least common in Asian males. And about 9% of men with prostate cancer have what I would call true hereditary prostate cancer. And I think we're looking at Sir Chris Hoy's case as an example here, because this is defined as 3 or more affected relatives, or at least 2 relatives who've developed early onset disease before the age of 55. Now, it's also worth mentioning, with the rise of obesity in our population, that both overweight and obese men are at an increased risk of disease recurrence should they develop prostate cancer, as well as earlier progression and development of metastatic disease. And they've also got a higher prostate cancer specific mortality. Now, we're not quite sure why this should be. It may be linked to the increased inflammatory environment that may occur in obese individuals and the metabolic irregularities that we know are associated with excess weight. And some studies have also reported that high-fat diets may increase the risk of prostate cancer. Now, it's long been a question as to whether vasectomy influences prostate cancer risk, and one large 38-year study did find that any risk of prostate cancer following vasectomy was small, but that supported a relationship between reproductive factors and prostate cancer risk. However, the Faculty of Sexual and Reproductive Healthcare Guidance advises there is no evidence of a causal relationship between vasectomy and cancer of the prostate, and a large American meta-analysis showed no association between vasectomy and prostate cancer. So I think we can advise our men who are requesting vasectomy that they are not going to put themselves at increased risk of developing prostate cancer as a consequence. Now, as we know, and this is something of a hot topic at the moment, there is no organised screening programme for prostate cancer as such in the UK, although there obviously is the NHS Prostate Cancer Risk Management Programme, which aims to provide information to us healthcare professionals in primary care to advise asymptomatic men aged 50 and over to decide whether or not to have a PSA test. Now, we must remember as well that around a quarter of men diagnosed with prostate cancer have a normal PSA, and this is why it may be combined with digital rectal examination as part of screening. And DRE is recommended in all patients with an abnormal PSA to aid decisions regarding whether biopsy is needed, although DRE as a standalone screening test isn't recommended. And NICE also recommends that a person should receive a diagnosis or ruling out of cancer within 28 days of being referred urgently by their GP for suspected cancer, including prostate cancer. Now, PSA levels also vary according to age, and a really important point to remember here is that the PSA test is not diagnostic, and they may also vary with race. Now, NICE have updated its guidance on suspected cancer in relation to PSA thresholds and referral for investigation, and they're saying under the age of 40 we should use clinical judgment. 40 to 49 is above 2.5 micrograms per litre, 50 to 59 above 3.5, 60 to 69 above 4.5, 70 to 79 above 6.5, and above 79, as with the under 40s, we should be using our clinical judgment. But a prostate biopsy shouldn't be offered just on the basis of a serum PSA level alone, partly because a negative prostate biopsy doesn't exclude a diagnosis of prostate cancer, especially if there's significant clinical suspicion or if the PSA level is persistently elevated or rising. Now, if there's a negative biopsy, but the PSA is still raised, then we should be following these patients up very closely, ideally with a digital rectal examination and another PSA within at least 6 months of the negative biopsy. And then, depending on those results, we could look at a repeat biopsy with MRI targeting. And a combined MRI targeted and systematic biopsy approach does improve the detection of clinically significant prostate cancer. And NICE do recommend multiparametric MRIs as the first-line investigation for people with suspected clinically localized prostate cancer. Now, if you ask 100 urologists whether they would like to have a prostate biopsy themselves, the majority of them, in my experience, would raise their eyebrows and say, no, thank you. And the reasons are there are both advantages and disadvantages to a prostate biopsy. So the advantage, obviously, is that biopsy may pick up a prostate cancer that an MRI scan misses. The disadvantages are that prostate biopsies find less than half of the clinically significant prostate cancers that MRI scans miss. And as well as this, they may also result in a diagnosis of clinically insignificant prostate cancer. And transrectal ultrasound guided or TRUS biopsies can cause complications that may be significant. And I'm thinking about things like sepsis, urinary retention, hematuria, and even rectal bleeding that may require hospitalization. Now, if we look at symptoms, as we all know, most men with prostate cancer are asymptomatic at presentation, and we only raise suspicions usually followed screening with PSA testing and a DRE. And lower urinary tract symptoms usually don't raise a suspicion of prostate cancer with us because these are so common in older men, and in fact are rarely the presenting symptom of prostate cancer. Although you obviously can get locally advanced prostate cancer, occasionally causing obstructive LUTS. And because of the significant crossover in symptoms between prostate cancer and other benign conditions, and I'm thinking of things like BPH and prostatitis here, it can make it very challenging to distinguish the diagnoses clearly purely on the basis of symptoms. If we look at staging prostate cancer, obviously, first of all, we look at non-metastatic and metastatic. So non-metastatic, as you'd suggest, is either localized disease confined to the prostate gland or locally advanced disease that's spread outside the gland capsule but hasn't spread to other organs apart from the seminal vesicles. Metastatic cancer has spread beyond the prostate gland to local, regional, or systemic lymph nodes or to other body organs. Now, as you know, for years we've used the Gleason and TNM methods as the approved scoring systems here, and I'm not going to go into those in any great detail in the interests of time, but obviously you can look these up in the show notes and online as well. But what NICE do now recommend is that we stratify the risks for all people with newly diagnosed, locally or locally advanced prostate cancer. And they talk about the Cambridge prognostic groups 1 to 5. And essentially, the group 1 has a Gleason score 6 and stages T1 to T2 with a PSA less than 10. Group 2 has a Gleason score of 7 and a PSA 10 to 20 and stages T1 to T2. Group 3 has a Gleason score 7 and a PSA 10 to 20 and stages T1 to T2. Group 4 has one of a Gleason score 8 or a PSA more than 20 and stage T3. And Group 5 has 2 or more of a Gleason score 8, a PSA more than 20, stage T3, a Gleason score 9 to 10, or stage T4. Now, treatment is quite widespread and may consist of observation, active surveillance, androgen deprivation therapy, radiotherapy, brachytherapy, radical prostatectomy, or a combination of 2 or more of these. And you've got anti-androgen therapy, chemotherapy, immunotherapies, and targeted therapies for metastatic disease as well. Now, NICE say that for localized and locally advanced prostate cancer, we should be looking at active surveillance or radical prostatectomy or radical radiotherapy. Now, the evidence we've got doesn't show a difference in the number of deaths from prostate cancer amongst people offered active surveillance, prostatectomy, or radiotherapy, but there is good evidence that both prostatectomy or radical radiotherapy reduces disease progression compared with active surveillance. There's also some good evidence that both prostatectomy and radiotherapy reduce the rate of development of distant mets compared with active surveillance. But about 45% of men with PSA detected prostate cancer are candidates for deferred management. And in men with comorbidities and life expectancy of less than 10 years, then the treatment of localized prostate cancer may well be deferred simply to avoid loss of quality of life. Radical prostatectomy, as I mentioned, removes all the prostate gland and both seminal vesicles along with the surrounding tissue to achieve a negative margin. Now, in men with clinically localized prostate cancer that wasn't detected through PSA screening, this type of surgery does improve prostate cancer specific mortality and overall survival compared to active surveillance. And laparoscopic radical prostatectomy is indicated for localized prostate cancer with no evidence of spread beyond the prostate gland or distant mets. Mustn't forget radiotherapy here. It's an important and valid alternative to surgery as the sole form of curative therapy. And the PROTECT trial found no difference between radical prostatectomy and external beam radiotherapy for all oncological outcomes. And we think at the moment that external irradiation probably offers the same long-term survival results as surgery and provides a quality of life at least as good as that following surgery. Androgen deprivation treatment refers to treatments that act by reducing the effect of testosterone and other androgens and so inhibit the progression of prostate cancer. And so we've got the LH-RH agonists and anti-androgens here, with the LH-RH agonists such as goserelin and leuprorelin inducing castrate levels of testosterone within 4 weeks. Anti-androgens, on the other side, cause apoptosis and inhibition of prostate cancer growth. So we've got steroidal forms such as cyproterone, and we've got non-steroidal such as bicalutamide. The good news, I think, though, just we mustn't forget, is that prostate cancer is often curable, with overall survival obviously depending on the initial stage of disease at the time of diagnosis. Men with low-grade prostate cancers, by which I mean a Gleason score of 2 to 4, are at low risk of dying from prostate cancer during 20 years of follow-up. And men with high-grade prostate cancers, by which I'm talking about a Gleason score of 8 to 10, are at relatively increased risk of dying from prostate cancer within 10 years of diagnosis. And I think that highlights the point that the earlier we can pick up our male patients with high PSAs and investigate them as to whether they may have prostate cancer, the better for them in the long term. But I do hope you found that podcast helpful with everything that's going on in the world of prostate cancer at the moment. But do have a look at the show notes that accompany this episode at GPnotebook.com, as I think they will be helpful. And we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts, as in this case. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and download free shortcuts to help improve the lives of our patients in primary care. But as always, thank you so much for listening, and until the next time, goodbye.